Good afternoon, everyone. Thank you so much for joining us today. I'm Genevieve with Rogers Behavioral Health. Eating Disorder Awareness Week is an annual campaign coordinated by the National Eating Disorder Association. This educates the public and the realities about eating disorders, as well as provides hope, support, and visibility to individuals and loved ones who are impacted by eating disorders. As a part of this year's campaign, Rogers Behavioral Health webinar is focused on Avoidant Restrictive Food Intake Disorder. And I'd like to give a quick shout out to our professionals at our watch party at our Oconomowoc location. Joining me today is Dr. Nicole Stettler, Executive Clinical Director of Eating Disorder Services, as well as Dr. Peter DeVries, Medical Director of our Adult Inpatient Eating Disorder Recovery at Rogers Oconomowoc campus. Welcome to you both. Before we get started, I do just want to give a quick overview of the presentation today and the format. The webinar is scheduled for 90 minutes. And to receive full CE credits, you do need to be logged on for the duration of the program. Your attendance will be tracked via Zoom login and logout records. A PDF of the PowerPoints, as well as list of references, will be available to you immediately after the presentation on your personal dashboard at ce-go.com. An email with a link to your dashboard will be sent to you shortly after the broadcast ends today. In addition, we will have this recording up on Rogers' YouTube channel within the next day or two for your review. Our speakers will give a 70 to 75-minute presentation. Thereafter, I will facilitate a Q&A session. If you'd like to ask our speakers a question, please use the Q&A function at the bottom of your screen. Once a question is submitted, we will review, and then our presenters will answer those at the end of the broadcast today. And finally, we have closed captioning for this program. Go ahead and take it away, Dr. Stettler.
Great, thank you so much, Genevieve. So I'm going to get us started today. First off, we have no disclosures to report. This is a summary of our learning objectives, what we're going to be covering in this program today, and a little bit more of a deeper dive. We're going to be kind of covering 3 different subtopics today, including some of the additional information that you see here. And then at the end, as Genevieve mentioned, we'll have a moderated Q&A. I know Genevieve briefly introduced both of us, but just wanted to also highlight some more about our professional and personal identities, and also wanted to acknowledge that our experiences and lack thereof based on these identities really inform what we bring to our research, to our clinical practice, and to our teaching, including what we're going to be presenting on today. So I'm going to get us started today with the first portion of our talk, which is going to be giving an overview of ARFID. And starting off with the diagnosis. So ARFID, Avoidant Restrictive Food Intake Disorder, is quite a mouthful. So I'll be referring to it as ARFID throughout this talk, a little bit easier to say. ARFID is a newer diagnosis. It was added to the DSM-5 when it came out in 2013. Although people in the field also like to acknowledge that it wasn't that these patients suddenly emerged in 2013 with this diagnosis. People with these symptoms have always been present and always been part of our clinical practice, but they were captured under different diagnoses. Most notably, many people probably met criteria for something like a feeding disorder of infancy or early childhood, although that diagnosis had its limitations because it referred to such a specific age range, or potentially being captured under other not otherwise specified diagnoses, like an eating disorder not otherwise specified. So ARFID kind of gave these folks a diagnostic home, kind of pulled them out of the shadows of some of these other diagnostic categories and into one diagnosis that is included in the feeding and eating disorder category. Because it's still a newer diagnosis, that feels weird to say after 11 years, but we know that research takes a long time to do. So research is still emerging, including on the epidemiology of ARFID. But I did include here a list of some prevalence estimates based off of the research we have so far, showing what the prevalence seems to be estimated for in general adult and general child adolescent samples. And one thing that I think is particularly notable if you are someone who works in a specialized feeding or eating disorder setting is that the prevalence there can be quite high. So you see a big range there, 5 to 64%. But I think that just speaks to the base rates of ARFID being higher among those more specialty settings. So I think it's worth going over the diagnostic criteria in a little bit more detail, because the research does show that there are still many healthcare providers who don't feel very comfortable with knowing what ARFID is or how to diagnose it, and that these criteria are sort of helpful to be aware of. So ARFID is an eating or feeding disturbance that results in a persistent failure to meet someone's energy, caloric, nutritional needs, as evidenced by at least one of the 4 criteria that are listed in the DSM. 3 of the criteria are a little bit more physically focused. So things like significant weight loss or failure to achieve expected weight gain. We often think about this with kids and adolescents as someone who would maybe fall off their growth curve, but it could also be someone who has been following their growth curve and then has an acute weight loss. A significant nutritional deficiency, those might often be picked up in blood tests, labs, things like that. Dependence on being fed through or receiving their energy through nutritional supplements, either through a tube feeding or through oral nutrition supplements. So those are kind of focused more on some physical criteria. The 4th criteria is a little bit more about sort of the impact of ARFID symptoms. And this criteria is defined as marked interference with psychosocial functioning. This one is probably the one that's the most subjective and up to clinical judgment, because who gets to determine exactly what marked interference with psychosocial functioning is? And particularly for those who might work with children and adolescents, one thing that I think can be a bit of a struggle is that what kids and adolescents define as interference with psychosocial functioning might be quite different than what their parents or caregivers might suggest is interfering in their daily lives. And also just want to make a note here that, as with all feeding and eating disorders, we would want to rule out things like lack of food availability or culturally sanctioned practices that might be contributing to these symptoms. If those things are better explaining what's going on with someone's eating and feeding patterns, then we would not give a diagnosis of ARFID. So aside from the DSM criteria, we do tend to see clinically and in research 3 main symptom presentations. These are not diagnostic subtypes. They're not officially diagnostic subtypes, but they are symptom presentations that we tend to see and that I think can be quite clinically meaningful in terms of planning the types of interventions that we might do. So the symptom presentations, one of the first ones that we tend to see is a lack of interest in food and eating. So these tend to be people who chronically have always had a low appetite, not been super interested in eating. That may have even started with feeding problems very early on in infancy. They may have even met criteria for something like failure to thrive very early on. A lot of times parents of kids will describe that as young kids, it was maybe hard to get them to stop doing what they were doing and come to the dinner table. They just didn't seem to be as interested or motivated by food or eating as other kids. And we can see that kind of persisting throughout their lifespan. The second presentation that we tend to see is avoidance of foods based off of sensory characteristics. So this tends to be a little bit more what we might think of as kind of classic picky eating, although we'll talk about that a little more in a second. But people who avoid foods because of the way they look, they smell, the taste, the texture of those foods, and that those things are, there are certain foods that have specific characteristics that they tend to avoid or dislike. The third presentation is someone who has a high level of concerns about aversive consequences of eating. They tend to be pretty specific consequences, things like fear of that a food is going to make them throw up, or a food is going to make them have an allergic reaction, or is going to make them choke. But sometimes it can be a little bit more nebulous. It could be something like a fear of abdominal pain, or just a fear of like not feeling good or discomfort that could also be contributing to that. Now, although I'm talking about these 3 symptom presentations, I also really want to highlight that these can overlap. We can see patients with 1, 2, or all 3 of these presentations. And there is some research evidence supporting these 3 presentations as well, and including, I think one of the most common areas of overlap that we see is between the first 2 on this slide. So someone who maybe has a lack of interest in food and eating and is also pretty selective in the types of foods that they'll eat based off of sensory characteristics. I also want to highlight here that although these are really common symptom presentations that we see and are pretty clinically meaningful, people have also highlighted that this isn't meant to be an exhaustive list. So you could think about someone who might meet criteria for ARFID, but who doesn't really fall into one of these buckets necessarily. And that is certainly possible. We wouldn't exclude someone just because they don't meet one of these symptom presentations. One thing that I think is kind of cool about these symptom presentations is it's led to some interesting theories and frameworks for thinking about some of the potential biological underpinnings underlying ARFID. And so I just wanted to highlight one of those particularly influential ones here. This is from Jenny Thomas and colleagues, their three-dimensional neurobiological model, where essentially they kind of took each of these presentations and they highlighted what might be some theoretical biological underpinnings of these presentations. So for example, for sensory sensitivity, people who avoid eating certain foods based off of the sensory characteristics that they present with, they've talked about abnormalities in taste perception or other sensory characteristics that might be going on and might be biologically underpinned. Similarly, for folks with a low appetite, lack of interest presentation, they've hypothesized that the brain regions that are responsible for appetite and appetite regulation, like the hypothalamus, might be implicated here. And for fear of aversive consequences, that presentation of folks, they've talked about some of the brain regions that are associated with fear responsiveness, like the amygdala and other parts that are connected there, might be responsible or play a role in the development of that presentation. So a couple of other diagnostic considerations, you might be already noticing that ARFID ends up being a very heterogeneous condition. You can have people who present very, very differently in your practice, but who both meet criteria for ARFID. There's actually been some cool research. One study a couple years ago demonstrated that using more lenient definitions of those criteria that we walked through earlier can actually double the number of individuals that are diagnosed with ARFID. So I think that really speaks to the level of subjectivity and clinical judgment and how that can change the net that is being used to capture these folks. There are also some criticisms about this. The fact that it's a really heterogeneous condition may mean that the diagnosis lacks some specificity that would really help us guide both our clinical practice and efforts. So, for example, developing a treatment approach that would work for all presentations of ARFID, as well as research efforts. So you're looking into research, to determine, for example, what may those biological underpinnings be, causes, mechanisms, but also what might be some of the epidemiological things, co-occurring disorders. Those might look different depending on the different presentations within ARFID because it is so heterogeneous. And one question that always comes up that I wanted to speak to when talking about ARFID is, well, isn't this just picky eating? Are we pathologizing picky eating? And that's a really great question. And I think always something that we want to be paying attention to. It's really similar, and I think of it a lot like with anxiety, right? We also don't want to over-pathologize anxiety. Anxiety is a normal, natural human emotion, and sometimes people might experience a lot of anxiety, but where it becomes a disorder is when it's really impacting their life and their functioning, right? So similarly, a lot of people are picky eaters. It's really developmentally normal for kids, especially in kind of the preschool, early school age years, to have a period of picky eating. But for some people, that can really persist throughout the lifespan. And it's really when that picky eating rises to the level where it's impacting physical health or daily life functioning that we would think about that rising to the level of meeting criteria for ARFID. But there also has been a little bit of research trying to look at this. And I wanted to highlight this one study that was among an adult sample looking at folks who would be classified as picky eaters and folks that met criteria for ARFID, and looking at some of the differentiators between those two groups. And they found that some of those differentiators included things like food neophobia, so the degree to which you have a strong reaction, fear, and avoidance of new or novel foods, the level of rigid eating behaviors, and also the range of foods eaten. So the kind of range that was identified here is that people who met criteria for ARFID versus kind of more typical picky eaters were eating from a range of foods that was about 20 or less. So really quite limited. Interestingly, though, self-reported sensory sensitivity, so how sensitive someone perceived themselves to be to things like taste, smells, textures, wasn't really different between these two groups. With all of these caveats, researchers and clinicians have been looking into how can we assess for ARFID more effectively and be able to determine who would benefit from this diagnosis. And so I'm not going to walk through these in tremendous detail, but did want to highlight some of the assessment tools that have been developed and are available, including a semi-structured interview, as well as some self-report questionnaires. Most of these are pretty freely available online with instructions for how to use them, and so are things that you could use in clinical practice to help you with screening or some differential diagnosis, or things that you could use in research as well. Speaking of differential diagnosis, I also wanted to just touch on differential diagnosis with restrictive eating particularly, because I think for many of us who work in the eating disorder field in particular, but perhaps beyond that as well, historically, when someone has come into our office and said, well, I'm losing weight and I just don't want to eat, our brains kind of jump to something like anorexia, or maybe something like an other specified feeding and eating disorder that really is kind of in the anorexia spectrum. So there has been some research kind of looking at what does differentiate, what are the differences between patients with more anorexia or anorexia spectrum disorders versus patients with ARFID. And I wanted to just highlight some of those group differences because I think that these can be helpful parts of the picture to pay attention to that might help give you a sense as you're trying to kind of negotiate and figure out what diagnosis might be most appropriate for someone. So first of all, patients with ARFID, on average, there's a younger age of onset or age at presentation, so tend to be a little bit younger. There's also a higher proportion of males in samples of patients with ARFID compared to anorexia or OSFED. Patients with ARFID tend to have more typical weight and shape concerns. That doesn't mean no weight or shape concerns. We know that body dissatisfaction, especially among particular subgroups, is quite common. So this is more saying that for patients with ARFID, they may present with some body dissatisfaction, but it's not the driving factor that is contributing to their eating difficulties and the reasons why they're not eating what they need to fuel their body. In addition, and we'll kind of see this with one of our case examples, that a lot of times for some people with ARFID, they may have weight and shape concerns, but it may be more about feeling too skinny, underweight, something like that. So it may be more about weight or shape concerns that as a result of their eating disorder, but something that they want to change and be different. In terms of the kind of eating habits, we see that there are similar levels of dietary restriction between patients with ARFID and anorexia, but patients with ARFID report a higher food neophobia. And there are different measurement skills to measure that, but that's kind of captured by this idea of what is it like to have a new food, something that you haven't had before, what's your response and reaction to that. Also can be quite helpful to get a good history of what people are eating, what are their preferred or safe foods. For patients with ARFID, not everybody, certainly, but on average, preferred foods tend to be more in the energy dense, high fat, high carb, processed, kind of white or bland food kind of category. And those tend to be foods that are not preferred by your patients with anorexia, where their restrictive eating is driven by a desire for weight loss or weight or shape change. Similarly, patients with ARFID, their diets tend to be low, again, on average, in things like vegetables and proteins, things that people tend to avoid because of taste, texture, smells, things like that. And again, for patients with more anorexia presentations, those tend to be things that would be safer foods for them. In terms of history, often, again, but not always, patients with ARFID have a more chronic low weight history instead of an acute weight loss when there has been a history of low weight or weight loss. That's not always the case, especially with the kind of presentation of fear of aversive consequences. Sometimes we do see that the onset can be quite acute after an event has happened. So someone maybe has an episode where they choke, or they start to choke, or feel like they might be choking, and then they stop eating fairly rapidly after that, and there's a really acute weight loss. But if we're seeing more of a chronic history of low weight, that tends to not be so much the case with something like anorexia, right, where we tend to see a little bit more of a precipitous weight drop. And then one hot off the presses study that I just included here, thinking more about the kind of other characteristics of these patients. There was a recent study that highlighted and looked at the role of delay discounting, and found that that's more common among patients with ARFID. So what that means is kind of more of a preference among people with ARFID compared to anorexia for more immediate rewards. So I kind of think of this as translating into maybe being a little bit more on the impulsive, a little bit less on the highly self-controlled. So that can be another kind of differentiator that we might see. All right, I'm going to talk briefly about co-occurring disorders in our last couple of slides before we jump into talking and introducing our case presentation. So with co-occurring disorders, per the DSM-5, we want to be thinking about ARFID as a diagnosis. That eating disturbance that we're seeing is really not better attributed or explained by another medical condition or mental health condition. This can be quite tricky because, as we'll see in the next slide, there can also be a lot of co-occurring disorders. So we might see, for example, someone who has maybe a history of a lot of abdominal pain. Maybe they even have some actual GI complications that have been identified. And then on top of that, there's some restrictive eating. So one thing that I often will think about is this next bullet point, which is, if the eating disturbance is occurring in the context of some other problem, is the severity of that eating disturbance kind of going above and beyond what we might expect? So a good example of this might be actually thinking about OCD and contamination concerns, right? So you have someone with OCD, they're really concerned about germs and illness and contamination and getting sick and things like that. So you can imagine a case where you might have someone with OCD and a lot of those contamination concerns who is still getting all of the nutrients that they need, and they're basically able to kind of get through life. They might be very impacted in other areas of their life, and that's meeting criteria for OCD, but it's not impacting their eating to such a degree that that really needs to be addressed outside of what we would just do to treat the contamination concern. On the other hand, we could see someone who has OCD, it's impacting a lot of their life. They're not able to do a lot of things because of concerns about contamination and illness, including maybe not being able to eat anything except maybe really specific packaged food, maybe not even that. And in that case, we might think that that's kind of going above and beyond, and something that we would need to address more quickly and have a higher priority of addressing in that context. Because if someone isn't eating, that is going to significantly impact not only their brain and their mental health, but also their physical health. I also often think a little bit about what is the kind of treatment that a person is going to need, and will that diagnosis kind of help them access the right kind of treatment that they need? So for example, giving someone with ARFID, or with that presentation we just talked about, an ARFID diagnosis might also help us be able to make sure that we've got a full multidisciplinary team on board who can help support that patient's total health. So make sure that they've got medical monitoring from a physician to make sure that their weight, their vitals, their labs are all stable while we're working on the contamination issues and eating. And I'll maybe also bring a dietitian on board to help with making sure that they've got kind of some meal plans, and that we're working together to figure out how do we start to increase what they're eating to support their body's needs, both in the immediate short term to just kind of keep them stable, and then in the long term to restore them back to full health. So with all of that said, this, again, I'm not going to go over and read all of these percentages, but just wanted you to have a snapshot of what are some of the co-occurring disorders that we often see going along with ARFID. This is based off of research to date so far. And again, like with many prevalence numbers, we see a lot of variability, but I think that this does speak to some of the common co-occurring presentations that we might see, both in terms of mental health and neurodevelopment, but also you'll see the last bullet point is about comorbidity with GI concerns. So thinking about if you are someone or know someone who works in a GI specialty setting, again, the base rates of ARFID are probably going to be a little bit higher in that setting because we do see some more common co-occurring and comorbidity there. All right, so I'm going to pass it over to my colleague to introduce our case example now.
Sounds good, thank you. Yeah, so I'd like to talk about a real life case example, just to go over like how a patient may present, what to consider upon initial presentation, and then how to kind of move forward with treatment. So we had a 19-year-old cisgender heterosexual male who was admitted to our inpatient eating disorder unit. He had been restricting for approximately 4 months or so after having a choking incident and then subsequent fear of choking. With his restriction, led to about a 54-pound weight loss in those few months. I'll go more into detail kind of about that presentation in the next slide. But in short, he really hadn't had much treatment prior to coming to us. I believe a lot of that was related to his kind of familial dynamics with mental health treatment. So many individuals in his family did identify as American Indian. They were from a more rural area, and in their family, they didn't necessarily believe in psychotherapy or mental health treatment. And it really created a pretty big barrier for him to seek and then receive treatment. I do feel like oftentimes in these cases, by the times these patients come to us and are actually kind of in our system, they can be quite medically ill. And I think that was the case in this situation as well. The other barrier that seemed to be happening in order for him to kind of not seek treatment earlier was related to his thoughts about masculinity, as well as being a male with an eating disorder. He was an amateur MMA fighter, and he kind of viewed discussing or showing emotions as a weakness. And so because of that, again, he hadn't really sought much psychiatric treatment in the past, other than just one prior inpatient stay right before coming to us for his weight loss and kind of restrictive behaviors. But again, really not much of a history of mental health treatment before coming to us. Go to the next slide. Yes, so I guess we can get into details of the presentation. So like I said, he's a 19-year-old male, history of eating disorder, some depression and some anxiety. Again, 4-month history of restrictive eating after a choking episode. He essentially had been slowly reducing his food variety over that period of time. Before that, he was eating kind of a normal diet and whatnot, a few meals, a few snacks a day. But at this point, he was really only consuming Ensures, which is like a liquid nutritional supplement. He would occasionally have milk and ice cream. But that was pretty much it. Only those 3 types of food for nutrition. Kind of going along with what Dr. Stettler was talking about before, much more like nutritionally dense, calorically dense food, a little bit more processed food as well. But when he did eat, he often engaged in chewing and spitting behaviors. I think he often missed the flavor or kind of the idea of food. And so he would put it in his mouth, he would chew it, but instead of swallowing it due to that fear of choking, he would spit it. Pretty much immediately before he came to us, he even had difficulty swallowing his own saliva because of anxiety. So he essentially would spit into a cup that he would carry around with him. So it was getting pretty severe. And again, with this level of restriction, he went from 162 pounds to 108 pounds. So pretty significant weight loss, especially just in a few months. He denied any weight gain fear. He actually instead desired weight gain. like Dr. Stettler was saying also earlier, it was kind of, he was not happy with kind of the body changes that were occurring. He very much wanted to be at his previous weight. He wanted to be more muscular so he could enjoy sports and things like that. There's really no history of like binging, no purging, no compensatory or compulsory exercise behaviors. He really was doing his MMA fighting because he enjoyed it and it was like a nice outlet for him. He didn't have any laxative abuse, no diet pills, no diuretics, no supplement use for manipulation of weight or body composition or anything like that. He did have very infrequent marijuana use, but none recently, none that I felt was contributing to any type of appetite or other issues. No alcohol or other illicit drug use. He did struggle with anxiety, obviously related to the fear of choking and kind of his weight loss, but he had anxiety outside of that as well, you know, in terms of school, like familiar relationships, other types of relationships. And he often felt his anxiety quite somatically, which I do think is fairly common in individuals with ARFID. So he oftentimes felt a lot of muscle tension. He felt very restless. When his anxiety would peak, he would feel short of breath. He would feel like his heart is racing or kind of palpitating. And then he also did struggle with depression as well. He had low mood recently. It definitely had worsened with the poor nutrition and with the weight loss and some of the physical symptoms such as like feeling really weak or really fatigued. And then more recently, just a lot of dizziness upon standing or like orthostasis. So I know it just went through a lot. So I would just ask us to pause for a second and think about possible diagnoses. I know that our title is pretty obvious about what the diagnosis I thought probably was, but just kind of thinking about like what other things you would want to run through to make sure that it wasn't. So for me, when I think of this case, I think of other potential eating disorders that can present as restriction, such as anorexia nervosa, atypical anorexia. Again, in this situation, there really wasn't any kind of undue influence on body image or waking fear. The cause of restriction was very clearly out of fear of choking. You know, you could look at whether depression really was the main cause, because oftentimes in our patients, there's just no appetite, there's no motivation, no drive, and things like that. But again, it clearly was after a choking incident, and then subsequently depressive symptoms seemed to worsen with that weight loss. So I thought that was probably a little bit less likely. Although I did acknowledge that obviously the depression was, in my mind, perpetuating to some degree the restrictive eating. And in any situation, and especially like this, I do think it is very important to rule out any medical causes. So could he be struggling with a true physiologic dysphagia, leading to difficulty swallowing and thus the choking fears? So in this situation, we did have the patient get a swallow study and an upper endoscopy performed prior to coming to us. And both of those studies were unremarkable. He had met with his primary care physician and they very strongly felt it was more anxiety based. So we felt pretty good about ruling out any organic causes that led to his perceived difficulty with nutritional intake. Go to the next slide. And any patient that comes to our unit, we give them a battery of assessments. And so these were his scores. So as you can see, he does have a somewhat elevated EDEQ. Interestingly, again, his shape concern was higher than we would normally anticipate for someone with ARFID. Again, in this case, it was felt more related to being self-conscious about the weight loss and desiring a more muscular body. So that's why his score was a little bit higher. Also, you know, showed some difficulty with life enjoyment and satisfaction, as well as a moderate level of depression. At the end of the webinar, I'll go over some of his end assessments to see kind of what progress we were able to make during his treatment with us. And now I'll discuss the current evidence as it relates to the use of medications to treat ARFID. We'll discuss any FDA-approved medications as well as off-label use of medications that have shown possible benefit. We'll discuss kind of what medication adjustments we made in our patient and how it was helpful or not helpful, and talk about some challenges that we kind of had along the way. I do acknowledge that there are many non-prescribers here in the audience. We'll try not to get into too much details necessarily about the specifics of our meds, but I do think it is important to just have a general idea of different approaches and what meds are out there that could be helpful. I also think it's really important to be aware of potential side effects of psychiatric medications and how those could exacerbate any ARFID symptoms. And so this is the list of the FDA-approved medications for ARFID. So in short, there's none. This is a newer diagnosis, so there just really isn't a ton of research that has been done on medications for ARFID. For now, we really just use medications off-label to help kind of with the symptoms associated with ARFID. So the following research and medications that I discuss really will be off-label. I'll try to break down the medication kind of by psychiatric medication classes and go over kind of the research based off that. So we'll start with antipsychotics. So the first that I'll discuss is aripiprazole. So it is a second generation antipsychotic. Again, not a bunch of research, but there was a case report that used aripiprazole to treat a patient, 15-year-old girl who had a choking presentation of ARFID, so similar to our patient, after witnessing her father choke. This then led to no solid intake for 10 months, about a 30-pound weight loss, and then with that kind of a very low BMI. She had experienced about 6 weeks of therapy, really not much benefit, and no solid food intake at that time. They ended up starting Abilify or aripiprazole nightly, which resulted in a decrease in anxiety with meals and improved solid food intake, and then also led to a pretty significant weight gain. The logic of aripiprazole or any of these antipsychotics as it comes to using them for treatment of eating disorders is often to mitigate the obsessional or at times almost like delusional thoughts towards body shape and towards weight. It can help reduce anxiety, and then a lot of our antipsychotic medications can increase appetite and enhance weight restoration as well. And so olanzapine is a good example that we commonly use in individuals who are underweight with eating disorders to increase appetite, support weight gain. There's also been some benefit for nausea, anxiety, and mood. So there was one study out there. It was a retrospective chart review of 9 patients with ARFID who received like additional olanzapine in addition to kind of their standard treatment. It did lead to significant increase in weight gain after they had received the medication. It also reduced associated anxiety, depression symptoms, and kind of cognitive deficits that occurred with their ARFID symptoms. CGI scores also improved. So they noticed benefit from about 9 patients. Risperidone is another atypical antipsychotic that there's one study, a case study essentially of a 4-year-old patient who was nonverbal, had autism spectrum disorder with severe misphonia, and they were admitted to an inpatient unit for dehydration and malnutrition. They started a very low dose that did lead to increase in oral intake, weight gain, and then decrease in those misphonia symptoms. Risperidone is FDA approved for autism spectrum disorder for ages 5 and above. And so they kind of saw some benefit in terms of the autism spectrum symptoms, but then as well as in ARFID as well. So those were, honestly, that's pretty much it in terms of antipsychotic medication. So again, a theme you'll see is just not a lot of necessarily evidence in terms of medications, but we can move on to the next slide then. In terms of antidepressants, mirtazapine has been studied a couple times for ARFID. Again, we often use this medication in our eating disorder population for those who are struggling with restriction and weight loss. It's known to improve or promote weight gain, decrease nausea, improve vomiting, and at times can help out with gastric emptying. So there was a study, a retrospective chart review of 14 patients who were given mirtazapine in an outpatient clinic. And those individuals had ARFID and no other eating disorder behaviors. They did see a pretty significant change in BMI after mirtazapine compared to before they were started on mirtazapine. So again, definitely promoted weight gain in individuals with ARFID. Most common side effects was drowsiness, which is very, very common with this medication. So we often give it at night. They did see that drowsiness actually improved as the dose was increased, which we do commonly see. Interestingly, they really only looked at weight gain, didn't look at anxiety symptoms or anything like that. There was another case of a 12-year-old female with multiple hospitalizations for ARFID, who eventually was started on mirtazapine during her third hospitalization. And they also noticed significant improvement in weight gain and appetite, but they also did notice improvement of an anxiety and a pretty significant reduction in nausea as well, which kind of allowed the patient to engage with the meal plan a little bit more than she maybe was before that. Surprisingly, there's not a lot of research out there either for SSRIs, which is our usual go-to in terms of depression and more generalized anxiety. There was a retrospective chart review of 53 patients, so that's kind of the biggest study that we've seen so far, looking at SSRIs alone or if they added hydroxyzine in addition to the SSRI. And so they assessed weight, eating behaviors, mood, anxiety, fear of food. And essentially when they added hydroxyzine, they did notice a difference in all of those above symptoms. So reduction in anxiety, reduction in fear related to food, and improvement in kind of restrictive eating. So yeah, they essentially noticed that it kind of facilitated meal plan compliance and participation in food exposures. And I'll talk about this a little bit later too, but I do think there are times when patients are so overwhelmed that it's even difficult to get them to the table, to even be around food. And so it's really difficult to do good kind of exposure work when we're at that spot. So I definitely think there is a role at times of medications to take the edge off to a degree. So then we're able to even just have the patient engage in any type of kind of therapeutic approach. Buspirone, we often use for generalized anxiety disorder. Again, there's only one case study of a 14-year-old female with restriction related to fear of abdominal pain, fear of emesis or throwing up, and that led to about a 5-pound weight loss in the last few months. Once they started Buspirone, they did notice an improvement in fear of vomiting and overall improved oral intake as well. So not a lot out there in terms of anxiety medications and how they might affect ARFID, but that was pretty much the only one out there right now. And then there are some more, what I would call miscellaneous medications that individuals have studied. So ciprofloxacin is often used in patients for appetite and weight gain in the eating disorder population, again, off-label. So these individuals performed a systemic review of ciprofloxacin, all ages, all populations, essentially as long as they were underweight. So it didn't necessarily mean it was only the ARFID population. It was kind of any individual with an eating disorder who was underweight. And again, it did promote appropriate weight gain. It did not look at any anxiety symptoms or anything like that. D-cycloserine is not something we commonly use, but this was a pretty interesting study. It is very, very detailed. So if people have additional questions on it, you can feel free to reach out to me separately. But he looked at behavioral interventions for ARFID plus a placebo medication or behavioral interventions with D-cycloserine. It was in patients who were 18 months or so. And so who met criteria for ARFID. And essentially what it showed is that it decreased the time to swallow and the decreased disruptions during eating. So oftentimes patients and younger patients who have high levels of anxiety with different textures of foods or feared outcomes, they can kind of become more disruptive or have some behavioral concerns that really get in the way, as well as kind of therapeutic approaches. And essentially what this study showed is that D-cycloserine kind of dampened that a bit and allowed patients to engage, again, more in therapy, and then kind of habituate to different food variety as well. One thing I really did want to talk about as well, and I think important for non-prescribers to be aware of, is kind of the role that stimulants can play in ARFID symptoms. So Dr. Stettler had mentioned earlier, there is a lot of comorbidity with ADHD in this population. And so these were 2 case studies that looked at individuals who had ARFID and who had ADHD. So one was a male who had ADHD symptoms. He was started on lisdexamfetamine, or the brand name is Vyvanse of that. And it really led to worsening of appetite suppression, stunting of growth, worsening of restrictive eating behaviors. What they did is they reduced the dose of this medication, then started the patient on risperidone. And with that dose reduction and the risperidone, it really led to an increase in appetite. He was able to weight restore. He was, and then subsequently maintain his weight for quite a long time. And then the other case study was a female, also with a very low BMI, who was started on Vyvanse, which led to appetite suppression and restrictive eating. They came off of the lisdexamfetamine or Vyvanse and instead switched to guanfacine for ADHD symptoms. And they were able to then restore weight very well and able to maintain weight off this medication. So something just to consider if you have a patient who has ADHD, maybe has some ARFID symptoms, and they started on a stimulant, just to be making sure we're really monitoring nutritional intake, weight, appetite, things like that, because there are other medications that can be effective for ADHD. For some, maybe not as much as stimulants, but there could be other options that could still be helpful and used without causing that appetite suppression or weight loss. And the other thing when it comes to ARFID is really just making sure that we are treating the other comorbidities. So again, lots of depression, anxiety, OCD, autism spectrum disorder diagnoses. And we know that there are medications that are effective for treating those. So not neglecting those comorbidities and making sure we're treating those effectively. We often see that with patients who are underweight or restricting, nutrition truly is medicine, and our medications are going to be more effective if someone is engaging in a meal plan. But at the same point, important to kind of treat their comorbidities. Antidepressants, though, often do come with their fair share of side effects as well. So, someone might have worsening abdominal pain or nausea or bloating or loose stools. And so we don't necessarily want to obviously exacerbate someone's ARFID symptoms with our medication. So just making sure we're getting a good history of what medications they're on. Has it led to any side effects or anything like that? And as a psychiatrist, making sure we are aware of our medications that we're prescribing, the potential side effects, and if we think that that is going to exacerbate, some of their symptoms, then trying to avoid it. For example, if someone had a fear of diarrhea, fear of loose stools, maybe I wouldn't go with sertraline or Zoloft. I would go with something that maybe had less of GI side effects and things like that. So for our patient, he was previously started on sertraline for his depression. He was on Depakote or valproic acid, which is an anti-epileptic medication, but most commonly used for mood stabilization in terms of individuals who struggle with psychiatric conditions. He honestly wasn't sure of why he was on this medication, and he didn't find much benefit of it. He was on lorazepam for anxiety, although it was a tablet formulation, and given his significant fear of choking, he had a very difficult time with tablets. So he essentially just wasn't taking it. He was also on risperidone for mood augmentation to help with the rigidity or obsessional thoughts associated with fear of food and anxiety. During his stay, we did make a few changes. So we were able to add hydroxyzine which off-label use for anxiety. The benefit of this medication is that it does come in solution form, given his kind of difficulty swallowing tablets. So he did find this to be quite helpful in taking the edge off, and being able to kind of engage with the meal plan and engage in exposure work. We also changed his lorazepam tablet to clonazepam, and clonazepam has a dissolvable tablet. So you kind of just put it on your tongue or in your mouth and it dissolves. And so then you have to swallow your spit, but don't necessarily need to swallow the tablet. And so that was just easier for him as well. We did end up doing that primarily before meals. And once we switched that, so once he was taking hydroxyzine and the clonazepam before meals, we saw a significant improvement in meal plan compliance, food variety, his ability to engage in exposure work, like I said before. Sertraline was also increased during his stay. Again, in the liquid formulation, and we noticed some improvement in mood, although I do think more so than the medication is probably his improvement in nutrition that led to that. And that's pretty much it from my end, so I'll send it back over to Dr. Stettler then.
Thank you so much, Dr. DeVries. So in our last third of our presentation today, I'm going to take the lead on talking more about therapeutic approaches to treating ARFID, and we will also return to the case study that Dr. DeVries has introduced to illustrate some of the examples of what we'll be talking about as we go through this. So this webinar is sort of perfect timing because we just got in December of 2023 a literature review of psychological treatments for ARFID. So this was a review of 50 studies that have been published as of December of 2022. About half of those were single case study designs. So I think that really speaks to this is still very much emerging. A lot of the literature at this point, there are no RCTs that I'm aware of for treatment of ARFID. So far it's been a lot of case studies, some case series, and then some pilot studies that have been released so far. The majority of these studies, about 80%, were with a child and adolescent sample. So there is also more need to look at treatment approaches in more adult populations. So with those caveats, I think what I really appreciate about the study is that it kind of demonstrates what I think those of us following the literature were already seeing, which is that a lot of the emerging treatment approaches really kind of tend to cluster around a few areas. So many of them are behavioral or cognitive behavioral in their approaches. There are also some folks that have focused more on a family therapy lens, and then many that are a combination of several of those elements. So that's where the field seems to kind of be hanging together in terms of how do we approach ARFID and address some of these symptoms. And I wanted to pull out some of the common treatment components that were included in these studies. And then we'll talk through each of these and how they kind of fit into some of the approaches we're going to talk a little bit about. So the common treatment components across the literature so far seem to include psychoeducation. Good place to start, psychoeducation about ARFID, what it is. I think just as healthcare providers, we're still gaining awareness about what ARFID even is and what are the symptoms and things that cause and maintain it. A lot of times patients and families aren't aware. And so even having some terminology to be able to label it, there's been so many families that I've worked with who have felt incredible validation from receiving their child receiving that diagnosis of like, this is what was going on. They often have this lived experience of saying or being concerned for years and years and feeling like those concerns were kind of dismissed or were just not able to be articulated in some way. And then once they had this kind of diagnosis, they were really able to say that resonates a lot with my experience. So psychoeducation about the diagnosis, about nutrition, and or about anxiety. So any or all of those things seem to be a common treatment element. Food exposure is another common treatment component. We're going to talk more about that along the way, as well as anxiety management and family involvement. So these are kind of where the field is, again, clustering in terms of where the evidence is emerging, suggesting that are the best care, best ways of practice with patients. All right, exposure therapy is something we're going to dive into a little bit more. So exposure therapy is a well-established treatment for anxiety disorders, OCD, things in that realm. The process of exposure therapy is really about making gradual contact with a feared stimulus, whatever is causing the fear, the avoidance. We have people engage in practice of exposing themselves to that, and then being able to work their way through higher and higher fears. Now, the mechanisms of exposure therapy are a little bit beyond the scope of this talk, but I'll highlight a couple of them that are theorized and supported in the literature. One mechanism by which we think exposure therapy works is habituation. This is the idea that if we face our fears without avoiding, then our anxiety does increase, but then it comes back down. And when we ride that wave of the anxiety and it comes back down, and we do that over and over and over again repeatedly, we become habituated. That peak of anxiety goes down over time to the point where we've kind of gotten used to it, and it doesn't cause us as much distress anymore. Another mechanism that comes out of the more inhibitory learning approach is more about corrective learning or expectancy violation. So this is the idea that we go into a situation where we are feeling fear or anxiety, expecting something bad to happen. And when we do that thing, and then we find out that that feared consequence doesn't happen, or it wasn't as bad as we thought it was going to be, then we get new learning that helps us recognize that we don't need to be as afraid of that situation or that thing in the future. As an alternative, sometimes we also do learn that the feared consequence may actually happen, but that we can tolerate it more than we thought we could. So that's another way that we can incorporate new information into as we kind of practice facing our fears. So exposure therapy, as we mentioned earlier, food exposures is one of those kind of common treatment elements, but I would argue that exposure therapy actually touches on and overlaps with a number of those treatment components that we talked about earlier that the literature is suggesting are part of best practice when treating ARFID. So we mentioned food exposure is one of those components, and we can absolutely do exposure therapy to feared or avoided foods. And we're going to talk about that a little bit more in a second. In terms of anxiety management, so as I mentioned in the last slide, exposure therapy is one of the most evidence-supported treatments for anxiety. So we can talk about anxiety management in terms of using exposure therapy to manage some of the other elements of anxiety that might show up with ARFID. One example of that is feared or avoided body sensations. Dr. DeVries mentioned earlier that a lot of times patients with ARFID might experience anxiety more somatically. And I think we especially see that with patients with more of the kind of low appetite presentation, but really across the presentations, we can see where there are experiences of body sensations that kind of cause them or distress, and then they avoid eating kind of as a result of that. And so we could practice using exposure therapy to help with reducing some of those fears or distress around those body sensations. Again, we'll go into deeper dives on each of these things, so this is kind of a summary. Also going along with anxiety management, those feared consequences of eating that we talked about earlier, fears of choking, vomiting, things like that. Also another place where exposure therapy really plays a nice role in helping with being able to manage those fears in a more effective way. And then not maybe directly related to exposure therapy, but I think most people who do really good exposure therapy, especially among kind of child and adolescent populations, but I think even among adult populations as well, would say that family involvement is really important to be able to support exposures, to be able to help kind of increase the effectiveness of that. And in particular, symptom accommodation is something that's talked a lot about in the anxiety and OCD literature as it relates to exposure therapy, and is something that might also apply very well to ARFID. So we'll talk about that a little bit more in a second as well. So taking each of these kind of in turn, let's start first with talking about exposure to novel foods. So this is important for people who have a really restricted variety of foods that they are eating, often because of those sensory characteristics, but it could be for other reasons as well, but something where it's kind of the newness of the food itself, like the fact that it's an unknown, the fact that I've never really seen or tasted or smelled it before. That newness is really making me say, oh, that is something I don't want to deal with. So along with applying the principles of exposure therapy, we want to be collaborative in identifying the foods with the patient and identifying what to work on. So what I often think about is kind of two sets of priorities. One is priorities based on nutritional needs. This is where the involvement of the multidisciplinary team working together with a dietitian who can kind of speak to what the current diet is looking like of that individual, and then be able to help identify what are the food groups or the other things, the types of foods that might be lacking in the types of foods that are missing from the diet that are causing a lack of certain micronutrients or macronutrients that we might need to focus on. So for example, if someone comes into my office and they're eating pretty well from most food groups, but they're not eating any vegetables, that's probably going to be a big priority, because if they're missing a whole food group, then nutritionally, I can probably guess, even though I'm not a dietitian, that's probably important for them to at least get some of those into their diet to make sure they've got kind of good balance. The second priority, or I won't say second, because these are both priorities, and again, depending on the particular patient, you may prioritize them slightly differently. But another set of priorities to think about is the types of foods that are going to help most with daily functioning. So what are the foods that someone may need to be able to have in their diet in order to be able to do the things they want or need to do in life? So this might include things like, what are the kinds of foods that are going to be easily accessible to them if they want to attend social gatherings? What are the kind of foods that families or whoever they're living with tends to eat at home that they may want to be able to take part in? If they are someone who really values traveling, let's say, then we want to make sure that they've got some foods that they can eat in different places that they would travel to, and that they can more easily find something that they could eat. So thinking about those things, thinking about the kind of physical health and then kind of the psychosocial functioning, working with the patient on those things to identify what are the top goals and priorities, and then being able to translate that into that hierarchy that we mentioned earlier. So how do we gradually work up to incorporating some of these foods? We can gradually increase that approach as well. Even for like one specific food, we can kind of make mini hierarchies. So there are steps along the way, right, to approaching a new food. We can look at it, we can smell it, we can taste it, we can bite it. These are all kind of different steps that we can take. Now, I do highlight that tasting does appear to be pretty critical. There's some research suggesting that, you know, all of the looking at and smelling and touching and playing with a food, it might all be great to kind of get someone a little more willing to approach it, but until they taste it, that's really where the rubber hits the road in terms of being able to help with the habituation. One piece of psychoeducation that I always talk about with my patients is the importance of multiple tastings. So the way that I kind of talk about it is that when we are tasting a new food for the first time, especially for someone with that really high sensory sensitivity, really high food neophobia, all we're going to get is this like overwhelming sense of newness. This is new, and that's all I'm experiencing is just the new stuff. And that is overwhelming and scary. So I'm not even really experiencing the food at that point so much as the newness. Now, the more that I taste something, that newness will kind of start to come down, and then I can start to really disentangle and appreciate the parts of the experience that are more, you know, the smell, the taste, the texture from there. So this is backed up by some research that shows that, you know, for most people, multiple tastings is needed to reduce food neophobia. Oftentimes this happens when we're so little that we don't even remember needing to have multiple tastings before we kind of got used to a food. But for those of you who are maybe parents or have had younger siblings, you might have experienced some of that yourself, of seeing a little kid kind of try something and eating multiple times before they got used to it, and then were able to kind of tolerate it or maybe even enjoy it. So with my patients with ARFID, I'll talk about like we need to do at least 10 tastings to get rid of that new feeling. And we may even need to do more. For people who are really sensitive, really have that strong food neophobia, we may need multiple tastings for them to habituate to that. The other thing that I like to know as a clinician, and sometimes we'll also talk about with patients, is just expecting that habituation may be a little bit slower than it is for kind of classic anxiety. And there's some people who have suggested that this may be due to the role of disgust as a distinct emotion. So we know a lot about kind of how anxiety and fear habituates. With disgust, which shows up with ARFID, kind of this feeling of like, oh, this food is just gross, like I just want to avoid it. It also kind of shows up in some presentations of OCD as well. Like contamination can have disgust involved with it. Those things do tend to be a little bit slower with habituation. So something to note that if it doesn't work right away, that just doesn't say stop, it just means kind of keep going. And that also may be a time to rely on more of that expectancy violation, corrective learning approach that we talked about as well. The other thing I always emphasize is that not all foods that someone tastes will ultimately be incorporated into their diet. This helps take some of the pressure off. The idea, I think a lot of times by the time that someone is a teen or an adult, and if they've been a picky eater kind of throughout their life, they've probably gotten so much of the experience of trying a new food and having people watch them like a hawk and be like, do you like it? Do you like it? Do you want to try it? Would you like to have more? Should I go out and buy some more? That's a lot of pressure, right? Then it's like, oh, I have to know whether I like it or not. And if I say yes, then I've committed to like being willing to eat it more in the future. So I like to take all that pressure off of it and just say like, nope, we're going to try it. You're going to try it until that newness comes down. Then you can make a decision about whether you want to incorporate it into your diet or not. And then, if you don't end up incorporating it into your diet in larger portions, well, then we might need to think about a different food, right? So let's say someone tries broccoli multiple times and they kind of get to a point where they're like, yeah, I just really don't like it. Okay, we don't have to have it be broccoli that's in your diet, but if you've got no other like green vegetables, we might need to find something else that will fit the bill, and let's work on identifying which one that might be. Dr. DeVries, do you want to take this, just kind of explaining how we applied food exposure to the case example?
Yeah, definitely. So again, as I mentioned before, I mentioned really only 3 sources of nutrition. So it was either Boost and Ensure supplements, ice cream, and then milk. Essentially what we did was we created a fear food hierarchy, like that ladder based off our menu that we have available to us on our inpatient eating disorder unit. We started with foods that the patient rated 3 or 4 out of a 0 to 7 scale. So definitely brought up a pretty significant amount of anxiety, but it wasn't like overwhelming. So maybe we avoided some of that like extreme disgust kind of symptoms. So we started off with soup, then yogurt, then mashed potatoes, and peanut butter. Initially started with just a couple bites, then kind of worked on increasing the amount of bites, increasing the amount of volume. We kind of repeatedly did this, 3 meals and 3 snacks a day. So even throughout the day, this was happening multiple times. As the patient habituated to certain foods, like I believe he habituated pretty well to mashed potatoes and yogurt fairly quickly, we kept those in and then reincorporated more foods to kind of work on. Eventually, when he was like, mashed potatoes are 0 out of 7, we kind of didn't throw it away completely, but maybe didn't do it as frequently. So occasionally we would come back to it, but it wasn't necessarily part of the routine kind of menu and what he was consuming.
Thank you. All right, let's talk about a couple of the other ways that we can apply exposures to treatment of ARFID. So I mentioned those body sensations earlier. There's some common sensations that may prevent someone with ARFID from eating enough. So particularly there's often complaints about fullness, bloating, nauseous, feeling nausea. So we can do some exposures to these. This is what's known as interoceptive exposures, right? So we're doing an exposure to the actual physical sensation itself to help someone practice recognizing that experience happens and that nothing bad happens, or that they're able to tolerate it more than they expected. We can do this both naturally and through contrived exposures. So naturally, this is probably going to come up when people are eating anyway. If they're someone who's really struggled with eating enough and we are helping encourage them to eat a little bit more, there's probably going to be some natural opportunities to practice tolerating the distress that might come up and riding that wave of anxiety. But we can also do some contrived exposures, meaning that we can have the patient do things that will bring about those sensations outside of a meal time. So these are some examples. These are taken from the CBT for ARFID manual by Cameron Eddy and Jenny Thomas and colleagues. So thinking about things like if there's a feeling of fullness that gets in the way, we can have people practice that feeling of fullness and riding out that wave of anxiety by gulping water, so that their stomach kind of feels full, but it's of water, and then they kind of get the experience of it, feeling that fullness and then having it pass. Similarly, I'm going to talk about more about how we applied it to the case example in a second, but wanted to also talk about exposure to feared consequences. Again, there are so many possible feared consequences that could come up with ARFID, fears, things that are causing someone not to eat because they're expecting something bad will happen as a result of them eating. So this really highlights the critical need for assessment. You really have to assess and know what the fear is, what are they expecting will happen if they eat certain kinds of foods. Some of the more common ones might tend to include fear of vomiting, fear of choking, fear of an allergic reaction, something like that. But again, sky's the limit. It could be many things beyond that. So always important to assess so that you can design your exposures to really address that particular fear. And then within this, we can also do a range of exposures. So we can certainly do in vivo exposures, meaning in real life exposures. So this can often look like for fear of vomiting, we might do, or choking for that matter, we might do things like having people listen to audio of people throwing up or watching video clips of people choking. So things where they're actually kind of witnessing something happen. We can actually even work up to having people sort of mock vomit. There's all sorts of vomit recipes on the internet that you can look up, and then you can have people make it and practice throwing up into a toilet, all sorts of fun, creative things you can do. But there's also some things that we may not be able to do in real life. An example of this might be, let's say that someone's fear is, if I eat this, I'm going to have an allergic reaction, and then my throat is going to close up and I won't be able to breathe and I will go to the hospital and I will die. That's the fear. Well, we're not going to do that as an exposure, right? We are clearly not going to have someone actually eat something that is going to cause that to happen, nor are we going to try to evoke that whole process from happening. But we still want to do some exposure to it. And this is where imaginal exposures can be really helpful. Having someone create a script of that worry that their brain is already giving them, and then repeating it over and over and over again. Again, it's the same process. Our brain habituates to the script, to those thoughts and images coming into the mind, so that they're associated with less and less fear over time, and someone can get through their life more easily without those thoughts and images bothering them. We can also do response prevention for safety behaviors. So things like if people are doing a lot of things like checking labels, cutting things into small bites, eating something, chewing something a certain number of times to avoid choking, that can be another part of our exposure, is helping cut those safety behaviors out so that they're getting to tolerate the anxiety of not doing some of those rituals that might be making them feel a little bit better. All right, Dr. DeVries, you want to share some of the examples of how we applied this in our case example?
Yes, definitely. Yeah. So in addition to kind of those more natural food exposures that we were doing, we also initially really worked on that response prevention for spitting the saliva into the cup. You could probably tell that would potentially impact his kind of social relationships quite a bit. And so we were able to essentially, what we did was tracked how much, or he tracked how much he was doing this, how much he was able to resist, and then how much he was able to submit. And kind of through gaining that insight, he was able to work on resisting quite a bit more. And by the end of his hospitalization, he was not using the cup at all. So that was wonderful. We then did a variety of exposures targeting his fears of choking, some of which kind of Dr. Stettler had mentioned in some examples. So swallowing 10 times quickly, watching videos of someone choking, working on taking larger and larger bites while thinking about choking. We also did do some in vivo exposures as it relates to medications. Sometimes the cost of medications can just be quite a bit more if we're doing dissolvable tablets or liquid formulations or things like that, but also not always feasible to do that. So we had kind of cut Tic Tacs in half and had him swallow that, and then full Tic Tacs, and kind of worked on things like that, which overall did go pretty well. Some imaginal exposures, imagining choking, kind of worst case scenario, interoceptive exposure, so kind of getting that gagging feeling, almost like choking sensation, by utilizing a tongue depressor initially on the kind of front part of his tongue and then going back. He handled that pretty well as well. And then, yeah, just natural exposures, kind of making him sit with some body sensations when eating to kind of tolerate that level of distress.
I'm noticing the time, and so I'm thinking that I have one slide, a couple slides on accommodation that I might skip over, and if there's questions about that, we can come back to that. But I want to make sure we have time to wrap up the case example. So I'm going to jump ahead to those slides and let Dr. DeVries wrap that up, and then we can move into our moderated Q&A. And if we have time, we can come back to those slides on accommodation.
That sounds good. Yeah. So again, he made pretty significant progress through medication changes, nutrition, through kind of the therapeutic work. So again, at the end, he was no longer spitting out his saliva into a cup because of kind of the band tracking that we were doing there. Reintroduced many, many new foods towards the end of the hospitalization. Our staff was selecting meals and snacks for him. He didn't know ahead of time what it was. He was sitting down, he was consuming it, and able to do it without too much distress, taking normal sized bites of foods, transitioned some of his medications from liquid or powder or dissolving tablets to just normal tablets. And then he had pretty significant weight restoration as well. So if you go to the next slide, I kind of just put it out in a graph. As you can see, the weight is in kilograms. So it really was able to make pretty significant progress with weight restoration throughout his stay with us. So that was wonderful to see as well. And lastly, I'll just talk about this change too. So what we did see pretty significant improvement in his EDEQ scores, as you can see, less concern over all of kind of every single subcategory, which was good. I didn't include it, so you'll just have to trust me. But his mood symptoms also did improve quite significantly. And then his quality of life was just, it was wonderful to see where he kind of ended up compared to where he came in. So overall, a very successful story, which is always nice for us to see.
Wonderful. Thank you so much, Dr. Stettler and Dr. DeVries. We will now begin our moderated Q&A session. Again, if you do have a question for us, please use the Q&A function at the bottom of your screen. I will be grouping some of the questions together into themes. And if we don't have time to get to your specific question, please feel free to send us an email follow-up to webinars@rogersvh.org, and we will get your questions answered. A lot of good questions coming through on the chat with several themes. One of the themes that popped up over and over again was the differential diagnosis between anxiety, OCD, and ARFID. How would you tease through those three?
Yeah, I can maybe start, and then Dr. DeVries, you can chime in with your thoughts. I think it's absolutely really important to note that they can co-occur, right? So I wouldn't necessarily say it has to be one or the other. I think that going back to what I said earlier about like if there is a significant fear or obsession and compulsive behavior that is driving a lot of the symptoms, I guess what I would think about that would kind of help me determine whether to go more down anxiety, OCD, or ARFID, or both, would be thinking about where the functional impairment is occurring. So if it's mostly occurring in a non-eating realm and it's not really impacting their eating in a way that is really causing, again, significant health concerns or significant psychosocial impairment, then I would be thinking more anxiety, OCD diagnosis would be sufficient. If it is all of that is happening, there's a lot of psychosocial impairment outside of eating in addition to eating, and that eating again is kind of rising above and beyond what we would normally see, and it feels like it warrants additional clinical attention on its own. Like we really need to treat the eating behaviors and make sure, because they're impacting someone's physical health or psychosocial well-being, then I would probably think about diagnosing anxiety or OCD plus ARFID. If someone maybe has some anxiety symptoms, but that doesn't seem like really the only place that it's showing up is with regard to eating, like they're having maybe a fear of choking, but the only way it's really impacting them is their avoidance of food, and it isn't really limiting them in any other ways, that's when I would probably diagnose something just ARFID.
Yeah, I would agree. I think from my perspective, it really is kind of deep diving into like, what is the fear, and how is it impacting us? So if the fear is very much related to food, nutritional intake, anything like that, then in my mind, it would make sense probably to diagnose it more on the eating disorder realm if it is then impacting us socially or weight loss or kind of all those different ARFID criteria. And kind of like what Dr. Stettler said, one, I think that that is completely accurate and true, but I also think like if we're losing a lot of weight, if we're medically becoming compromised, like having that eating disorder diagnosis can get us into probably the proper treatment that we need in terms of like just what our basic needs are. So like we need to get back on nutritionally in order to truly work on OCD or anxiety or anything like that. So if we're losing weight because of these symptoms, then it makes sense to have that eating disorder diagnosis in there.
Thank you. Another question. I work with clients with chronic illness who often have to make significant dietary changes or complete elimination diets, such as the low FODMAP. In your experience, are these clients at increased risk for developing ARFID? How can clinicians support them during this process to reduce the likelihood of developing ARFID?
Yeah, my thought is there's probably not a whole bunch of data out there for us to completely say like absolutely these patients are at an increased risk of developing ARFID. I do think that likely they are at an increased risk. I think it would potentially be based on like previous symptoms. So in my mind, if someone had previous diagnosis of an eating disorder or ARFID or any type of kind of eating or feeding concern, and then you are asking them to significantly reduce their food variety or oral intake, I do believe that it could kind of lead to resurgence of those eating disorder symptoms. And so I think especially in those cases would just be so important to be meeting frequently, kind of seeing how they're doing with things, making sure they're seeing a medical provider, kind of getting their weight checks and things like that to make sure we can kind of stay on top of it. I think also important to have a really collaborative approach in those cases with the individual who is making those recommendations. I think sometimes, patients who are struggling can kind of take that and then expand it further and kind of restrict their diet even more than it needs to be. And so I think just making sure we're working really closely with the GI specialist or the dietitian or whoever it might be to make sure that everyone's on the same page. I don't know if Dr. Stettler, you have more to add to that.
I agree with everything that you said. I think a couple of things that I would add is, yes, I don't think there's too much data about this, but I think absolutely clinical experience kind of bears that out. And actually not just for ARFID, I've definitely had conversations with like my colleagues who specialize in areas of GI where more like kind of an anorexia or like orthorexia presentation has come about as a result of some of those elimination diets. And I think we don't have a really great systematic way of there's so many risk factors that are out there, and they all don't have such a degree of specificity that we can clearly say, if you have this level of risk on these risk factors, then this is not indicated. So I think it really does come down to the monitoring and the supporting, and I think just continuing to check in on how that's going. If people are having, with ARFID, I would be thinking more about additional kind of worries, concerns. Are they overgeneralizing? Like, have they been kind of, told by whoever is kind of prescribing their specific diet? Have they been told to eliminate certain kinds of foods, but then they're kind of going above and beyond that? That would be sort of a key thing for me of kind of wondering why they're doing that and what benefit that they're seeing. And then absolutely, I think that close collaboration and, at some point it might be a consideration of just like with medications, right? Like risks and benefits. Like, if someone does have a predisposition for something like ARFID and they also have these chronic illnesses, we may need to balance for that individual what are the risks and benefits and how do we kind of maximize the best of both worlds to maximize their quality of life.
Thank you. Several questions about the exposure process and exposure therapies. I'll bundle a couple of them together. How frequently do you recommend clients engage in food exposures? One time a week, weekly? Do you encourage families to be a part of that process? Let's see here. And if somebody's unable to put the feared food even near their mouth? How do you help a clinician walk them through that process or that reframing so that it's successful?
Yeah.
I'll let you take this, Dr. Stettler.
Sure. Happy to start, and then again, absolutely chime in with additional thoughts. In terms of frequency, I think some of that probably depends a little bit on like level of care that you're working in and degree of impairment in functioning. I will say, some of this has been if you're working in an outpatient setting, I would really rely on the manual that's currently published on cognitive behavioral therapy for ARFID, because I think that is the best supported manualized treatment that we have, with some coaching there. And they're talking about weekly appointments, but they do also recommend people engage in exposure homework at home throughout the week as well. So probably every day is a good thing to shoot for, and then probably just like anybody who's ever treated, anxiety or OCD or really anything in assigned therapy homework, also being expecting the fact that you're probably not going to get daily, and then helping with like some motivational interviewing and some incentives and figuring out how to problem solve to help people increase it as much as possible. Oftentimes with patients, I'll just say, the more repetitions that we get, the more quickly, the faster this whole process will go. So it's kind of up to the patient and the family, how much time and effort they can really invest in that. But I think, trying to shoot for daily is probably good. And then certainly at higher levels of care, we might be thinking about doing it, multiple hours a day for multiple days a week. Definitely families being involved, I think, is super helpful, again, especially for kids and adolescents. But, the CBT for ARFID manual actually also talks about for patients who are adults and who are needing some weight restoration or weight gain as part of their treatment goals, having those supports is also really helpful, because it can be hard to stay motivated and keep yourself on track and accountable. So I think that having family involvement or involvement of supports more broadly can be helpful across the age range. I think for family members of kids and adolescents, and I know I didn't get to touch super much on the accommodation slides, but one thing that I think we can really borrow from the anxiety and OCD literature is working with parents on things like accommodation of symptoms and trying to reduce that as part of exposure, and also working on reducing criticism. A lot of times there's a lot of frustration that has built up in these families by the time that they get to treatment, because parents feel like they've tried everything for years and years, and so they kind of go between being super frustrated or kind of overly accommodating because they just want their kids to eat and they're just trying to do whatever they can to get by. So kind of helping them reduce those criticisms, recognize that we're all working together on the same team to try to challenge the ARFID and kind of make some small steps in progress, and then having them be involved as a coach or support for a loved one that's going through treatment. I think there was one other bundled question that I'm forgetting from that group.
I do remember it. I can chat on it.
Great.
Yeah, that was.
I think you covered it.
Yeah, the question on kind of the if an individual isn't even able to kind of get to the food and things like that. I think if it is like the individual isn't able to get to an extreme variety of food, then probably need like a higher level of care than what we're doing now, so they can have a little bit more support. So, I'm coming at things from an inpatient perspective, but if we're in like a treatment center where there's eating around other people, we oftentimes do have to do some accommodation. So maybe we have that patient eat alone and not next to other peers. And maybe we do have staff kind of walk them through it with them. I think the most important thing, or one of the important things when doing that, is kind of setting that expectation up front that while we may be doing this now, this is not going to continue to happen necessarily. And so the goal will be to not have to rely on staff to kind of engage in exposures and things like that. The other thing is, I think at that point, that's when medications can be truly helpful. To take the edge off, to allow the patient to even get to the table to engage in any type of exposure work. As someone kind of can be involving themselves in exposure response prevention and is going well, then we can talk about like decreasing the dose or tapering off, and seeing kind of how the patient responds. But I think that's a good opportunity probably to use medications.
Thank you. You both touched on it a little bit. There are a couple of questions around if a patient does need a higher level of care, do you recommend referring somebody to an OCD program, an eating disorder program? Like, how do you navigate if a patient needs more than outpatient therapy for this?
I think that's when sometimes, you know, in my mind, just reach out to Rogers, and they have wonderful admissions staff who goes over a wide variety of questions. And they're kind of experts on telling where patients kind of probably would be best helped and best served. You know, if there's any type of like medical complications or really significant weight loss, or their heart rate's really low, or their blood pressure is getting low, or their food variety is so poor that they can't engage in anything besides ensures, like, you know, that's probably when like inpatient is needed. But again, we have inpatient, we have residential, PHP, and IOP. And so my thought would be just reach out to an admission staff, and they can kind of help out kind of with any recommendation at that point.
Thank you. Well, that is all the time we have for questions today. Thank you so much. Again, if we did not get to your question, please send us a follow-up email at webinars@rogersbh.org. And again, as we start to wrap up here, we do want to remind you that a recording will be available on our YouTube channel within the next couple of days for you to review. If you did attend the entire time, you will receive a link within the next 30 minutes for your personal your ce-go.com dashboard, so that you can download not only the presentation slides, additional follow-up links, but you will also fill out your evaluation, and that's where you will also get your CE certificate for today. Again, if you have any questions about this presentation, you can also email support@ce-go.com if you need any additional supports. Our community relations liaisons are happy to connect with you to talk about Rogers services and how we can better assist you in your patients in their practice. And Dr. Stettler, if you would go one slide over. And here are some places where you can find additional information on today's webinar. Thank you so much for joining. Have a great afternoon.